Good evening, everybody. This is Facebook Live for the Plastic Surgery Support Forum. I am just checking to see if everybody can see me and if everybody can hear me. I do apologize, I've got a bit of a cold, so apologies for coughing if I go along. Now, Trish, can you see me? Can you maybe type something in so I can actually see if everything is working? Presume it is. Oh, message from Trish. Pardon me. I'm on as visiting guest. Just waiting to see if you can see it. I can see 3 or 4 people are watching, so I am presuming then that this is working and we are live. If you can see me, if you can hear me, just send a message through. Oh, I got a little tick there. No idea who that one was from. Ah, it's Trish. Yeah, fantastic. All right, so we are rolling. Pardon me. Okay, so this is going to be an interesting live chat, I guess, or Facebook Live. Hey, Narelle, how are you? Hope you're feeling good today. This will be an interesting Facebook Live chat, as I was saying, because this is open for anything. I'm very happy for everyone to ask essentially any questions regarding plastic surgery, but in particular, we're going to focus on how do you know that you're going to see a proper doctor? How do you know that you've actually seen someone with the appropriate qualifications and what to do in that consultation to give yourself, one, peace of mind, but also to give you the power to ask questions and feel comfortable that that surgeon is the correct surgeon for you. So, no problems. And Tegan, thank you so much for coming in today. It was really lovely to meet you. I didn't expect you to be up on Facebook Live, so it's great that you're here. Look, please, if there's something I've forgotten, or if there's something you still want to ask, by all means, please do so. So, look, I think probably the first question that needs to be answered, the first question that you feel, when somebody decides that they're going to have a plastic surgical procedure, whether it be something like a breast augmentation or a tummy tuck, I think the most important question you need to ask yourself, or most people do ask yourself, is who am I going to go to? And how you choose that surgeon can be just as important as the operation itself. And I think that that's really, really important. So you probably heard a lot in the media, you probably hear a lot about it in social media, because in effect, that space, that information space is flooded. And it's flooded with good information and it's flooded with bad information. And it's very hard often for someone who's not medical, and in particular not plastic surgical, to work out exactly where the right sort of path is. Probably the biggest thing that most people hear, most people have to choose, is whether the surgeon you're going to see is a plastic surgeon or whether the surgeon you're seeing is a cosmetic surgeon. And even now in 2019, I have patients who come and see me and say, what's the difference? I thought you were all cosmetic surgeons, or I thought you were all plastic surgeons. And unfortunately, that is not the case. So probably the first thing I can say is using myself as an example, but clearly I'm not the only surgeon you can go to. But I'll use myself as an example in this. I am a specialist plastic surgeon. And by calling myself or tagging myself as a specialist plastic surgeon and specifically using the terms plastic surgeon, I position myself in a manner that tells my patients or people who are researching me about my credentialing, or I should be able to explain it to you. So a plastic surgeon is the only surgeon, the only doctor whose training is approved and accredited by the overseeing bodies in Australia. And the main ones are the Australian Medical Council and APRA, which is the Australian Health Practitioners Registry. So if you're looking for a surgeon whose training has been approved by the overseeing Australian federal body, then the only surgeon that is allowed to do that in Australia currently is a plastic surgeon. As a plastic surgeon, we finish our medical degree. So we finish 6 years, 4 to 6 years of medical degree training. Most doctors will then spend another 3, 4, in my case, 6 years of pre-training to start your plastic surgical training. You will then do 2 or 3 potentially years of what's called unaccredited training. And unaccredited training is when you're actually doing plastic surgical work, but you're not on the training scheme yet. And so while you're learning, you have a limited number of things that you can do because you still need support. I guess it's like an apprenticeship, but you're the junior apprentice. And then after that, you apply, may take you a couple of goes, to get on to the accredited training program. Now, at that stage, you're the equivalent of an apprentice to a senior surgeon, and you're working with not just that surgeon, but multiple surgeons around multiple hospitals around Sydney, Australia, wherever you're going to go. Now, that training takes 4 years. Following that 4 years of training, you sit an exam. And I can tell you from personal experience that that is the hardest thing I have ever done in my life, bar none. It is one of the most difficult examinations you will ever sit. And I don't begrudge that at all, because what that means is that that is quality control. When and only when you are ready and the college and the examination guides us that we are ready to be let loose, if you like, by yourself on your patients, and you pass, that's when you get the title of a specialist plastic surgeon. After that, most of us spend 1 or 2 years doing fellowships, learning even more, before you come back and open up your practice. Now, if you look at that in totality, for most of us, that's between 15 and 20 years of study and training and hands-on work in all aspects of plastic surgery, including all aspects of cosmetic surgery, 15, 20 years before we actually start operating on our patients and call ourselves plastic surgeons. Now, a cosmetic surgeon does not have to do that. A cosmetic surgeon is a doctor who has finished their medical degree, right? The very, very basic first thing. Now, after that, currently, there is absolutely no law in Australia that says you can't just rock up, open your rooms, and say you're a cosmetic surgeon and start performing breast augmentations. And therein lies the problem. There are a lot of people with a lot of different levels of training, all of whom call themselves cosmetic surgeons. They are not members or part of the College of the Royal Australasian College of Surgeons. There are similarly named colleges out there helping to muddy the waters, but the only proper and Australian approved college is the Royal Australasian Approved College. These surgeons then add to the mix and say, well, we're a cosmetic surgeon. In the case of a surgeon from Emu Plains that you might have heard about and seen recently, he called himself an aesthetic surgeon. He's the only one in Australia who's an aesthetic surgeon. It's just a name that's made up. But call yourself an aesthetic surgeon, call yourself a cosmetic surgeon. These titles have no weight other than the paper on which they're written. These titles are not approved by APRA. These titles are not approved by the Australian Medical Council. So when you go to this doctor who calls himself a cosmetic surgeon, you have no idea of the level of training. It may be a weekend course. It may be a couple of years doing some work watching people. It may be someone who's just finished medical school and failed and has decided, I still want to do this. That is your decision. That is where you decide, well, do I want to go to that person? Or do I go to somebody who's a trained plastic surgeon who's got 15 to 20 years of experience? Now, in no way, shape, or form am I saying that a plastic surgeon is perfect and can't make mistakes and, you know, we never get things wrong. Of course we do. We're all human. All plastic surgeons make mistakes. No one will ever deny that. But what I think is important to say is that if a mistake is made, in the off chance that something does go wrong, being operated on by a properly trained person who knows what to do if there's a problem, being operated on by a properly trained person who works in an accredited hospital with an accredited anaesthetist significantly improves your chances of having that corrected and also significantly reduces the chances of having had a problem in the first place. So choosing your surgeon is your first decision, and the decision between plastic surgeon and cosmetic surgeon is often the decision factor that some patients make. Sometimes it's price-based, and we'll discuss that as we go along. But when you choose your surgeon, I think it's very, very important to look at your qualifications and make sure that they have a degree, a qualification that is approved by an Australian standard government training, and that is the Royal Australasian College of Surgeons. No other degree is approved in Australia, no matter what anybody will tell you. Now, hi Fiona. 2 years later and you're happy. Fantastic. That is great to see. I need to see you at some stage. You need to drop by and say hello. M. Freeland, you have sent a question. Oh, you've sent it as a PM. Okay. If it's something that I can help answer, please let me know. Kendall, you would love to know a little bit more about fat grafting to use in a breast lift augmentation, please. Oh, excuse me. Actually, that's a fantastic question, Kendall, because it is something that is becoming more and more and more common, and definitely in my practice has now become a big focus in my practice, and something that, you know, a few years ago I probably wasn't doing as much of. I personally now really, really love fat grafting, and there's a few things to talk to you about that. So probably the simplest thing, the first question most people ask is, what is fat grafting? So fat grafting, as we see it in a cosmetic situation, particularly in a breast lift augmentation situation, is taking fat from somewhere else and putting it into the breast. That's making it really simple, but that's essentially what we're doing. The difficulties, the complexities of the procedure, in essence, is how you put it in, where you put it in, where you take the fat from, and how you achieve better contour and curves when fat grafting. So what is usually required? Now, there are a lot of patients who have some thin skin over their breast, and so if you put an implant into them, it's a little bit obvious. And what you want to do is soften the curves. You want to make things a little bit softer, a little bit less obvious that there is an implant underneath there. So that's one group of patients. There's another group of patients who, for example, you do a breast lift on, who don't really want an implant, although they do need more volume. Now, you might not be able to achieve the exact amount of volume you could with an implant, but you can fill the upper pole, the upper half of your breast up a little bit better with fat grafting, and so you end up with a nicer shape, a nicer volume of the breast that you've got without necessarily having to go down the path of putting an implant in. So there are really, really great uses for fat grafting, for camouflaging, for improving the sort of the décolletage line in the midline, and from from a breast reduction or breast lift point of view, adding more volume to the breast and helping improve a shape to a point where in some patients you don't need to go down the path of a breast lift, with the benefit that it's all natural and it increases and decreases with you as you gain and lose weight and feel soft. That's a really great procedure, and it's a really good adjunct to have. The way that it works is that usually I get my patients to pick areas where they don't like fat and want me to sort of liposuck it away. Believe me, everybody seems to find somewhere that they would very likely want me to take some fat away from. While it's not the biggest liposuction on the planet, so don't expect heaps of fat to be taken away, but certainly if there's little love handles, if there's a little bit of area underneath your belly button, for example, we'll take that fat. We treat it then in a special way, sort of spin it down using a centrifuge or different techniques, wash it down, purify it, if you like, as a simplified term. And then we put it into syringes, and whether we've put it in after an implant or whether we've put it as a lift, we then inject the fat back in. And we overcorrect. So it's something that's very important to realize, that when we put the fat in, we don't just put in the amount of fat we think you need, we actually put in more than that. Why we do that is that we know that anywhere from 30 to 50% of the fat can fade away, cannot take, because it's a graft. And so when we overcorrect it, we hope that when it comes back down and that amount goes away, you're left with the right volume. And that you've got to take into account the eye and the skill of your surgeon. Sometimes though, too much of it goes away, and you might need a second go at it. So when you have fat grafting, you need to accept that you may need more than one go to achieve your final result. I hope that helps you with your question there, Kendall. Can I see me? Looking forward to seeing you. Is fat grafting more or less expensive than an implant? Look, that's a really good question as well, because sometimes you can have fat grafting instead of an implant, or you can have fat grafting with an implant. It boils down to your surgeon to a degree. It also boils down to the type of implant you use. Different type of implants have different pricing. Pardon me, as you would have, most people would have heard in the news recently, there's been a whole bunch of things going on with the implants, which also add to the mix of whether you would want an implant or not. That's becoming a significant part of the conversation I have with my patients who need a lift and some sort of volume. So that's also something to think about. As a general rule though, just being very sort of general, when you put an implant in, you're paying for the implant and the surgical skill. When you're doing fat grafting, you're paying for the liposuction and you're paying for the fat grafting. If you do it once, it's usually cheaper. But if you do it twice, look, you do have to take that into account, because fat grafting at the moment, just like implants are, there's no Medicare item number for that, so that is a fee. So it can vary, but certainly in my practice, as a general rule, it's actually it's not as expensive as an implant. All right, I'm just going to scroll down and see what the next question is. Now, I had a question. I'm just going to get this from Trish. Here we are. I had a question from Trish for some questions from tonight. Let's see. Here we are. Right, so one of the questions I was asked, and I'll give you, no worries, Kendall. One of the questions I was asked was, this is one here, and hopefully the person responsible is seeing this. I have heaps of excess skin after losing 60 kilograms. Now, this is a very common scenario, and want to know if what exactly I'd be covered with Medicare. I don't have private health insurance. My skin is saggy and baggy and hangs over my mons area. I'm guessing I need a body lift, breast lift, and possibly an arm lift and thigh lift. Can you guide me in the right direction to get the best help I can? Look, that's a very common question, and that's certainly a question most people who have lost weight and want some sort of body contouring, body tailoring surgery ask. And my practice, as most of you know, is focused on breast and body surgery. And so the vast majority of work that I do is post-weight loss, post-pregnancy. So what we call mummy makeovers and what we call post-weight loss body contouring surgery. So that's what I do a lot of. In fact, it probably forms about 80 to 90% of my practice. And so this question pops up a lot, particularly in patients who don't have private health cover. The simple answer to this is there is no simple answer. There are procedures that carry item numbers because they are associated with weight loss, or they are associated with symptomatic weight loss that you can then claim through Medicare. Now, I think it's important to take a step back and say, well, what does Medicare give me? If you have an item code for your operation, as a general rule, that operation should be able to be done in the public health system. So if you have a trauma, if you've got a breast cancer and there's an item code, you're going to be able to get that operation with an item code done in the public system. If you've lost weight and you've got a lot of skin and that operation carries an item number, then the question obviously arises, well, why can't I do that in the public system? And the answer, quite simply at the moment, is it's all about allocations of funds. There's a large volume of people who are in that situation, and the operating takes a lot of time. And if you then go ahead and do that in the public system, you find that it is going to take up more time and resources than is currently available, and you miss out on operating on people with breast cancers or cancers. So the government sort of made a decision to say, right, fine, we're going to take these ones, but these are procedures, even though they have item numbers, aren't really going to be done in the public system. There might be a wait list. You could go on the wait list, but you'll never essentially get done because you'll always be trumped by a skin cancer or any type of cancer. So what's the point of having the item number and not going into a public system? And so the reason to get an item number for your procedure is that if you have an item number, that procedure does not attract a GST. So if you went, because it's a medically approved number, it's not a pure cosmetic. So the operations, first and foremost, we can only do in the private hospital. So if you're going to go into the private hospital, you're going to get charged for these. Let's for the moment assume you don't have private health fund as this patient has. You're going to get charged for these, but you're going to get charged without the GST. You're going to get charged by the surgeon, by the anesthetist, and most importantly by the hospital for the number of days you're in the hospital, but also for the operating theatre time. Now they can charge that with GST or without GST. In this situation, because it's not inverted commas cosmetic, it's without GST. Now that's a 10% saving on what you would normally have paid had you done this operation without an item code. That's the first way to think about it if you don't have private health fund. If you do have private health fund, because your procedure carries an item code, it means that for the most part, if you are at the right level of cover, and obviously that's a personal circumstance thing, then you may have to pay an excess to the hospital, but your hospital stay and the time in theatre is covered by a health fund. So this procedure, provided you've got private health fund, is then covered at the hospital. Part of your surgeon's fee is also rebated, and part of your anesthetic fee is also rebated. Now that's not all of it, and it does depend to a degree on your surgeon, but most surgeons, it's not all of it, leaving you with an amount to pay. Now that amount, if you have private health cover and you've gone down this path, is way less than if you didn't have the item number for the procedure, or you had gone in as a purely cosmetic procedure. So it's a little bit complicated, but it does give you a little bit more back in your pocket than if you didn't carry an item number. So what that then means is that if you're doing that procedure, you're doing it in the private health system as you would, you at least get something back, you at least get some sort of support, but it's not everything. Um, Patients who lose a lot of weight, there's a lot of operating to do. And there are some procedures that work well with others of that surgery. And some of those procedures can carry multiple item numbers. So 2 or 3 procedures may be able to be combined if they, and you may have 2 or 3 item numbers. Sometimes, like when we do a tummy tuck or when we do a body lift, the government has essentially said if you do that and you do another procedure that used to carry an item number, you might not be able to combine that together. And that's something that your surgeon or your practice manager at your surgeon's practice should be able to help you out with. The aim being that you combine the procedures that give you the maximum benefit and do it in a way that when you're doing the surgery, you're getting maximum benefit each time and saving you at least 10%, but ideally more. So yes, you can do these operations with Medicare rebate in the correct circumstance, but no, you can't do these operations purely with the Medicare rebate. You still need to go to the private system, and having a private health insurance is going to significantly improve the amount of actual rebate and refund that you're going to get. So hopefully that's a bit long-winded, but hopefully that sort of explains that question. It's a very complicated question in many ways, but it's a question that gets asked all the time because these operations are not cheap. They're significant investments that you have to make, and you need to look at how much more and how as much as you can get into your back pocket, but also then how much can you get the hospital, etc., to be paid for. Now, what's the next question? Here we go. Okay, so the next question I've got, yep, no one's asked, we haven't asked a question there, so I'm happy to go down here. Shona Spruster. Okay, g'day Shona. In terms of textured implants potentially leading to a small number of breast illnesses, yes, very, very good question, very topical at the moment. Should we consult our surgeon if we have textured silicone implants currently in situ? Yes, I do think that you should speak to your surgeon if you have textured implants currently in situ. I think it's very, very important for your surgeon, for me as I'm talking to you right now, to emphasize though that you should not be afraid, you should not panic, and you should not be stressed by the information that has come out currently. Why is that? Because the information we currently have is not absolute. We know some things, but we don't know everything. So rather than going out there and having a big panic in the street saying, look, I've got textured implants, I need to have them out, I think you need to have a look at this with a grain of salt right now. What we know right now is that a very, very rare cancer, ALCL, is more prevalent if you have had a breast implant, in particular, textured breast implants. Now, if that was as simple as that, fine. I think everybody, the TGA, FDA, the FDA in America, everyone would just go, hey, textured implants, all textured implants, stop. We're not going to use them because all textured implants cause breast cancer, this type of ALCL, this type of cancer in the breast. The story is not that simple. We know that there are probably a good way to think about it is if anyone's ever been to Bunnings, you've got different textures of sandpaper. You can have really coarse sandpaper, you can have really fine sandpaper. And it's a very similar way to explain the texturing on an implant. You can have macro textured implants, which is the coarse ones, and you can have micro textured or nano textured implants, which are the fine ones. Now, what we know is that over 85% of the people who have developed this cancer have done that in those coarse sandpaper implants, the macro textured implants. We know that if you're in the community, your normal chance of getting this cancer is about 1 in 100,000. If you have the coarse sandpaper implants, it drops down to around 1 in 3,000, 1 in 2,800. If you have the fine sandpaper ones, it's dropped down to about 1 in 86,000 or thereabouts. So if you've got a fine textured implant, your rate has dropped from about 1 in 100,000 to about 1 in 86,000. If you've got a coarse textured one, your rate has dropped from 1 in 100,000 to about 1 in 2,800. Now that's a big drop, I grant that, And that's why everyone is talking about, well, do we need to use these macro textured implants? And my personal opinion is no, but obviously that's something that's going to be discussed further. But I think you need to also look at this in context and realize that while that is a big drop, your chances of getting breast cancer can be anywhere from 1 in 12 to 1 in 64. And if that's the case, and most women would not expect to get breast cancer, then even a 1 in 2,800 is a reasonably rare risk. But if you had to choose between 1 in 2,800 as a risk ratio or 1 in 86,000 as a risk ratio, I'm pretty sure, as most of my patients do, all of my patients do, no one's going to pick the 1 in 28. They're going to pick the 1 in 86,000 if they choose to use a textured implant. Smooth implants at the moment have not been implicated, although that data is still slightly fuzzy, but as far as I can see, smooth implants have not been implicated. So look, if you do have a textured implant and you're listening to all this stuff that's coming out in the media and you're nervous and worried about it, you don't have to go to your surgeon if you can't get a hold of them. You can certainly go to the Society of Plastic Surgeons website and ask there. You can ask on forums like this. You can call up and speak and get some reassurance. Ideally, if you do contact your surgeon, it gives you an idea of the type of texturing you've got. You may find out that you had a micro-textured implant, which is a very different risk ratio. And it should give you peace of mind, and it should give you comfort and stop you from worrying or panicking too much. This is not currently a situation where everybody who's got a textured implant needs to go and get their implants out. It's not that type of thing that's happening right now. Now, I don't know what's going to happen tomorrow. I don't know what's going to happen in a year's time. We are doing some significant research in this, so I can only tell you what I currently know. But as far as I know, at the current amount of information, this is far more prevalent in macro textured, the coarse sandpaper type implants, which are banned in many countries overseas, or at least suspended. And I suspect that's what's going to happen in Australia as well. I hope that answers your question. Liz, g'day Liz. How long do you need to wear compressions for a thigh lift with lipo? My patients, my answer is very simply, I like this for 6 weeks. My patients, and I think most surgeons will tell you their patients fall into two categories. After 6 weeks, you'll wear them and keep wearing them because you like them, or you feel comfortable, or you feel a bit more secure, and you can wear them. Patients will buy a few and wear them for 6 months, a year, just for support. It's kind of like medical Spanx, if you like, and it does help. Then the other half of my patients cannot wait to get rid of their garment as soon as the 6 week comes along. I will get phone calls at 5 weeks going, it's 5 weeks and 3 days. Is that enough? Do you think I can take it off? So look, it's difficult to say depending on where you are going to fall in that spectrum. But as a general rule, I personally like the implant, garments on for 6 weeks, and then it's a personal preference how much longer you want to wear them for. But in an ideal scenario, minimum of 6 weeks. Kirsty Lee, my apologies. You're curious to find a rough estimate of the surgery you're interested in, and it's obviously very personal and depends on circumstances, degree, etc. But I'd love a ballpark figure to know how much I need to say roughly. Sure, Kirsty. My first question to you is, what surgery are you interested in? You've left that message, but unfortunately you haven't actually told me what surgery you're looking for, unless I've missed it earlier up, but I'm looking through that and I can't find that. So perhaps if you want to send me a message or DM Trish and she can send it to you, and I can certainly help you with that as best I can. Amanda. G'day Amanda, how are you? How long does it take for symptoms of implant illness to take effect? Very, very good question, Amanda, because I guess the biggest question that needs to be answered is, what is breast implant illness? It means different things to different people. Unlike, say if you had breast cancer, we know what we're talking about. There's a few different types of breast cancer. There's DCIS or LC, lobular carcinoma, LCIS or LC. There's, follicular cancer. The breast cancer can be split into 3 or 4 different types. And then we can look at each one of those and stratify it and say, well, this type of cancer takes this long to come through. This type of cancer has these symptoms, etc. With breast implant illness, or the term that has been coined breast implant illness, at the moment, as I said, it means different things to different people, and it's become, in essence, an overlying umbrella term. And it makes it very difficult then to say what or when breast implant illness as an entity comes on. For some people, breast implant illness is purely just pain following breast implants, but they put it into the category of breast implant illness. Some patients have described what they call mind fog or brain fog and said, well, that's breast implant illness. Some people are saying, well, look, I have these breast implants and I get skin rashes and I've lost hair, etc. And that gets put into the category of breast implant illness. Nobody denies, and certainly a good surgeon or a doctor that you're seeing should never, ever deny that you're having these symptoms. I don't think anyone should say, oh, there's no such thing. What are you talking about? That's just in your head, or there's no link, whatever. I don't think that that's the right way to approach this. I think the symptoms that women are experiencing, while it is a small population of women, I think the symptoms that you're experiencing are genuine and real and may very well be related to your breast implant. Some women just don't live well with breast implants. Currently, though, in all the literature that we have, in all the research that we've done, and all the associations that we've done, we haven't been able to see a Y follows X when it comes to the global breast implant illness. So we haven't been able to see that if you have a breast implant, you get brain fog, or if you have a breast implant, you get hair loss. Now, that does happen to some people, but we have not been able to find the link. Nothing we have done so far, nothing we have tested, checked, and looked at has been able to show a concrete correlation between breast implant and the symptoms that a lot of these women are experiencing. Now, we also know that if we take the implant out in some of these women, symptoms get better. But we also know that if we take the implant out in some of these women, symptoms don't get better. So it's a term, it's a situation at the moment that is a little bit too global, a little bit too diffuse. So to say you've got breast implant illness and when does it come on, it's hard to say, because what symptom are you referring to? Is that symptom really related to a overarching sort of implant illness? Is that symptom a connective tissue disorder that may or may not have happened to you, whether you had an implant or not? These questions are very, very difficult to answer. So I think what's important is to say that you might have symptoms. Those symptoms may be related to your breast implant, and those symptoms may get better if we take the implants out. But at the moment, based on current literature and current scientific evidence, we can't say that's definitely a link and a cause. Now, and we're doing a lot of research on this. So it may very well come out and say, yep, there is something and we can find it, we can see the genetics, we can check the DNA, or we can see where this is, and then it becomes an easier thing. But as a surgeon, as a doctor, it's very important to present to our patients evidence-based medicine. I can't just say to you, well, I think that's what's going to happen and do it, because I have to back that up with evidence. So the evidence at the moment is not quite there. The clinical feelings from patients, there are patients that have these symptoms. We need to acknowledge that. We need to say that, yes, there is something there, and we need to deal with it appropriately per person. But at this point in time, you can't lump everybody into the one box and say everybody needs to be treated this way. I hope that helps. Kirsty, okay. Breast lift and tummy tuck. Yep, by all means, Kirsty. Send through a PM. We'll have a little bit of chat about that. I think it's important to remember that when it comes to any surgery, there are three significant cost factors. Well, actually four if you think about, if I think off the top of my head. And then, pardon me, that can be stratified. So the first cost in surgery is the cost of your surgeon, the surgeon's fee. The second cost is that of the anesthetic doctor, the anesthetist, if your procedure requires a general anesthetic. And then the third cost is the cost for the hospital, time you spend in hospital, and the operating theatre. The fourth cost, which I throw in, is also the time taken off work and the time to recovery. And some patients would like, it's important to factor that in, that there is a loss of income potentially for some women and men. And you need to factor that into a degree as well. So there are four different types of costs. But when you see a surgeon, you essentially get a quote that doesn't take into account how many days you're going to lose off work, but it does give you a quote on the surgeon's fee, the anesthetic fee or estimate, and the hospital estimate. Now that can vary a little bit depending on how many hours it takes to do the surgery, what the anesthetist is, and some doctors have already got a pre-arranged relationship with their hospital, but those are the things that you need to look at. Then, just to muddy the waters a little bit more, it depends on your private cover, whether you have it or you don't, and it depends on the level of cover. Because when you throw that into the mix, if your operations that have been listed carry item codes, as I was mentioning earlier with the weight loss, then you can reduce potentially the hospital fee, get a better rebate for your surgeon and anesthetist, and that can be a saving as well. And then your overall fee can be reduced as well. So there's quite a few little calculations that need to be made before you work out what your final fee is. So it's awfully difficult sometimes when someone calls your rooms and says, hey, how much for a breast augmentation? Actually, that's probably not the best example because that is something that's reasonably fixed sort of around the place. But if someone says, oh, I want to lose, I want to get a body lift. You might need a body lift, you might need a tummy tuck, or you might need a tummy tuck with a fleur-de-lis pattern. All of those have different fees because they take longer in theatre and the technicality of the operation is different. And so in that situation, you can give a ballpark figure, but until the surgeon actually sees you and really looks at you and works out what they need to be, then and only then can you get a proper sort of idea of how much your surgery is going to cost. So it's a bit that gets involved. It's quite involved, both from our point of view and also from the patient and hospital point of view. So yeah, Kirsty, send us that information and we'll certainly be able to help you with that. Another question I got was that how long after breast lift or breast reduction surgery can you drive or lift young children and get back to the gym? My girlfriend said she started lifting her 1-year-old at 2 weeks, but she's a single mom, so I guess she had to. Look, that's a very, very good question. And it's a very difficult one to answer accurately because different people recover at different rates. But the human body, pardon me, the human body, there are some things physiologically that happen at around the same time. The best way that I describe most of my operations to my patients is to think about a footpath. Yeah. And when you look at a footpath and if you just put fresh cement on it, you don't go walking on that. So from week 0 to week 6, you've got fresh cement, you've got soft cement, you don't want to be walking on that. You're just going to fall straight into it. And it's going to stuff up the footpath. From week 6 to week 12, it's that footpath where you can get a stick and write your name in it. It's firmer, but if you're standing there for too long, you're going to start sinking in it. So you can do a lot more at that time. And from week 12 onwards, it's a footpath you can walk on, and that's not a problem. So in terms of exercising, in terms of heavy lifting, those type of activities, week 0 to week 6, most things are no. Walking and simple exercises like that are okay. Lifting less than 5 kilos for me is okay, but more than that, you've got to be very, very careful. Depends to a degree in the operation, but for a breast lift or a breast reduction, you probably get away with it. Certainly you wouldn't with a tummy tuck or a breast augmentation. And then from week 6, you start to exercise more, you start to build up a little bit more. You don't go crazy, but you do that around week 12, you get back into it. Most people will be back to work for most procedures that I do between 7 to 10 days. And when you're getting back to that work within 7 to 10 days, it's probably okay to drive. You get checked by your surgeon first. But if you're comfortable, if everything's all right, if your scars aren't in the way, if the wound hasn't broken down, and certainly within a week to 10 days, driving is okay. I do recommend to my patients that, hey, put a pillow in between yourself and your seatbelt to give a little bit of extra padding, and that can help. So look, it does vary between patients, and it sometimes does vary between what the patient needs to drive for or work for. But I think 1 week you pretty much don't do too much crazy things. But after a week, depending on what it is and what operation you've had, you should start to get back to a more normal life. There's an anonymous. No worries, Kirsty. The aim is to be as honest as possible with these things. I think if you're not, what's the point of being a proper plastic surgeon if I stand on one side and say, come to a proper plastic surgeon because we'll be honest about it, and then not do the same thing myself. So, no, that's fine. Anonymous question: do I use Motiva implants? Yes, I do, but in a limited capacity at the moment. Why? Motiva is a beautiful brand. It seems to be doing very well. It's popular amongst a lot of my colleagues, and it certainly has come up amongst the ranks very quickly. The concept of having a nano-textured implant is very appealing. And for those who don't understand, when we were talking about the sandpaper grading, you've got the coarse sandpaper, which is the macro-textured implants. You've got the fine sandpaper, which is the micro-textured implants, which is the ones that I use. For example, Mentor brand uses that. And then you've got these new ones, which are called the nano-textured implants, and they kind of feel like paper. They don't quite feel like sandpaper. But if you were to look at them under a microscope, you'd see the same ridging and shape pattern as you do with really fine sandpaper. It's just taken it another level down. And the thought process behind texturing is that it integrates with the tissue better, it stops teardrop implants from rotating around, and it reduces the risk of capsular contracture if placed above the muscle. It's roughly the same if you place it under the muscle, but those are the reasons for texturing an implant. It's important not just from what the body tissue sees, but also what the cell sees. And the cell, at the cellular level, the nano-textured implants, the ones that are Motiva, have the amount of texturing that a cell needs. The micro-textured implants, the fine ones like I do with Mentor, have texturing that the cell sees, but it's quite big from a cell's point of view. And then the macro-textured are just ginormous. It's the Grand Canyon, so to speak, in reverse. So the theory behind Motiva is that it can achieve, and it can certainly do, everything that a micro-textured implant can do, but it doesn't need to feel like it's got texturing because of this nano-textures, because it's more important to see what the cell sees and not what the surgeon sees. There is a reasonable amount of logic in that, and their studies are almost 10 years now of clinical studies of these implants. And that's where I'm currently sort of getting to the point. Most plastic surgeons, certainly someone like myself, as I mentioned, I like the evidence. I like to see 10-year data. I think, before you start to use things significantly, you want to be comfortable that a 10-year follow-up hasn't really shown anything out of the ordinary. Motiva is getting very, very close to that. And once it crosses the threshold, I think I'll be using a little bit more to get more familiar with it. So for the moment, I am in I guess you could call it a trial basis of Motiva. I need to see how the gel works. I need to see how that looks on my patient. I need to see if my patients are happy, and I need to see if my technique and the implant meet each other and marry well. I know that my technique and Mentor implants do very, very well for my patients. So will it be the same thing with Motiva? These are the sort of things that me as a surgeon and surgeons think about before they swap to anything new or anything different. What's the evidence? Is it safe for my patients? And if I do use them, am I going to get equivalent results or better results? If I'm getting less than equivalent results, there's no point using. So that's where I am at the moment. That's the sort of stuff that I'm looking through. And all I can say is watch this space, because certainly this year I'll be using them more. But I will only use them to the extent that I feel comfortable that they're doing the right thing by my patient. And if I feel that that's the case, then yes, certainly I'll use more Motiva, and my patients will have that choice. If I feel that it's not as advertised, then I'll be letting my patients know as well. Excuse me. G'day, Melanie. If I have only a bit of fat on my inner thighs, can that itself be lipoed alone without a full thigh lift? Look, without seeing you, it's a difficult question to answer, but a small amount of fat, yes, the answer is that you can have liposuction and you can get a good result. It does depend on where that fat lies. It does depend on a few factors, like not just the fat, but the quality of your skin and the amount of skin stretch that you have around that area. Because sometimes you can take the fat away and the skin might not retract with the fat, even though it's a small amount, and you then have like an empty bag of skin hanging around. What you don't want is a different muffin top, or migrating the muffin top to a different place, as I tell my patients. So I think depending on the amount of fat that you have, yeah, look, there's a potential that something like liposuction would work. There are also non-surgical techniques such as cool sculpting that might suit you, but it's a decision that needs to be made only after seeing the area and seeing whether removing that is going to leave you with an overhang, leave you with a shelf, or whether it will be able to be camouflaged by your surrounding tissue. It's a little bit harder on circular tissue, thighs and upper arms, because as a circle, as a barrel, tissue moves from the other sides to fill it in and can affect the contour. But I guess it breaks down to, as I said, what you mean by a small amount and where it's located. Not every patient who's got some fat on their inner thighs needs to have a proper thigh lift. Liposuction can be the right choice, depending on the patient. Yes, so Melanie, that's your legs drop together. I think that's probably the pardon me. I think that's probably the main point. Most women that I see who want a thigh lift or a thigh-related procedure want thigh gap, want a little bit of space between the two thighs because the skin is touching together. And if that can be achieved sensibly and safely with liposuction, then that's all you're going to need. But as I said, if the volume is large and we take it away, and yes, you've got less fat, but the skin is hanging there, that may chafe and rub as well. So the thigh gap is probably the biggest area that we have to consider that for, and in the right patient, liposuction can work. But again, depending on your surgeon, you need to see that and make that decision together. Kendall, do you have enough control when having a breast lift to decide what desired shape you want? Also, has technology progressed nowadays to leave minimal scarring? I'll answer the second question first. Has technology progressed enough nowadays to leave minimal scarring? Technology certainly has progressed in terms of scar care, skin care cream, things such as IPL light or light therapy. There are a lot of new technology, skin needling. There are a lot of technology that can help improve a scar, that can help camouflage a scar, and that can help make a scar fade better or indeed sometimes more quickly. Yes, we certainly have technology for that. Do we have technology that is going to leave minimal scarring? It's a very difficult question to answer because scarring is not a factor that technology creates or causes. Scarring is an inherent genetic component, and scarring is what the surgeon did to you. So if the surgeon positions the scars in a nice place, if the surgeon is able to camouflage that, you're going to have minimal scarring anyway. But if you do then go on to develop scarring, yes, there are techniques that we can use to make it better. But we, at the moment, don't have the ability to stop you from scarring. So one of the things I say to my patients for a bit of a laugh is, look, when I do the operating and you get really good scars, you can thank me. If you get really bad scars, you can blame your parents. So that's something you need to sort of think about from a scar point of view. Do you have enough control when having a breast lift to decide what desired shape you want? Yeah, absolutely. I think as long as your expectations are realistic, as long as you understand that a breast lift can only go so far. It can improve the shape, it can improve the distance and length of the nipple from where it currently was to where we want it to be. It can improve the amount of upper pole fullness, certainly with things such as fat grafting. Then yes, you can control the shape of the breast to a reasonable degree. When patients have a breast augmentation and a breast lift, the usual conversation is that the surgeon creates the shape and then the implant creates the volume. And then the implant helps train that breast to a degree. So by all means, yes, as a surgeon, part of the technique, part of the skill is to help develop a breast into a shape that you and your patient are happy with. There are some caveats. It's like with anything in plastic surgery, it's what you start with. If things are really quite difficult, then you might be able to bring it closer to the normal, but it might not be able to get it to perfection or the normal. If what you're expecting is, a magazine cover model breast following a breast lift, and your breasts are nowhere near that to begin with, then you and I have to have a conversation to find a middle ground where we're both going to be happy. I think expectations have to be managed, but yes, certainly. Having a lift and shaping the breast pre-implant or without needing an implant is something that your surgeon can certainly do. All right, that's good to hear. Well, look, guys, it's 8 o'clock. We might call it quits unless there's some extra questions if anyone wants to ask me quickly. I will have daycare duties very soon to put two little munchkins to bed, and I'm going to have to do that shortly. So if there aren't any major questions, look, there are some questions here that Tricia sent me that I will answer, and she can put that up on the forum as well. The other thing to let everybody know, and certainly hopefully pass on the message, is that there is a breast and body surgery information night coming up that we'll be hosting here at Sydney Cosmetic Sanctuary in Leichhardt. So if anybody is interested, or if you have friends or colleagues that are interested and you'd like to come along, give the rooms a call. It's a night where I will be presenting on different types of breast and body surgery and providing information. And that's also a great forum to sort of meet, chat, and have a quick consultation, a short one, to see if that can help you make a decision as well. So that's coming up. I think it's on the 16th of April, so it's only next week. It's only a week away. And we do try and keep these things to a discrete number. We don't want a lot of people because it's discretion, and it's also people a little bit concerned about talking in live forums sometimes. So the seats are limited, and we would we'd love to see you there. Any further questions? Let's check. All right. Okay, everyone, have a lovely evening, and please contact Trish or contact my rooms directly if you've got any particular questions or you'd like to see me about something in particular. More than happy to help out. Thanks, everyone. Have a good night.